Hi, everyone. I'm Kevin Caldwell, founder and CEO of Ossium Health. I'm going to talk a little bit about the work the company has done over the last several years and some of the projects we have ahead. So we very often talk about cell and gene therapies as sort of the cutting, leading edge of medicine. But one thing that we like to ground people in is that the original cell therapy is, of course, the bone marrow transplant. And bone marrow transplants have been around for 70 years. In that time, they've been used to treat more than 70 different blood and immune diseases. So there are a few challenges with today's bone marrow transplant ecosystem. Firstly, there are too few donors. About 40%, actually close to 45% of all the people who go looking for a bone marrow donor today do not successfully find one. The second major problem is speed. Even people who do ultimately find donors typically spend anywhere from 3 to 5 months waiting for a donor before they receive one. And then finally, there's dosing. The current paradigm is based around finding volunteers, aspirating their bone marrow or mobilizing their peripheral blood, and then using those cells for the transplant. It virtually never happens that you go back to a donor and ask if you can drill into their hip a second time and take additional bone marrow. The dose that you get is the dose that you infuse. So here are some of the consequences of that. Every year, there's about 18,000 people around the United States diagnosed with a hematologic malignancy who actually go looking for a bone marrow donor. So about 4,000 of those people succeed at finding a related match. The very first thing that the hematologist does is check the siblings and then other relatives to see if they're a match. If they have that, great, they're done. You have another 5,000 people who use an unrelated matched donor. These people use the National Marrow Donor Programs, Be the Match Registry to find a match, and that's the process I talked about that takes 3 to 5 months before. You have about 700 people, and this number is getting smaller every year, who actually receive a cord blood transplant. So this is considered a last resort, especially for adults, but it is an option if they don't otherwise have a match. You have fully 9,000 people who actually go looking for a bone marrow donor who do not receive a transplant. Now, most of these are people who died during the process of searching for a donor. Some of them are people who just became so weak during that process that they were no longer eligible for a bone marrow transplant. So here are some of the consequences of that. There's a very powerful relationship between the disease stage that the transplant is done at and the patient's likelihood of survival. We can see that the person's probability of still being alive after 5 years, in broad strokes, goes down by about 1% with every additional sort of 3 days you wait for the transplant. So what do we do about this? Well, all three of the problems that I mentioned before, availability of donors, speed of the transplant, dosing, they're all constrained by the source that we use for the bone marrow transplants now. Our entire bone marrow transplantation ecosystem for 66 years has been based on looking for largely unrelated volunteer donors and asking them to step forward and provide bone marrow for transplant. But of course, that's not how our organ transplant system works, at least not for the most part. About 80% of all the organ transplants that are done in the United States are actually done from deceased organ donors. And so the first insight behind Ossium was to leverage this existing deceased donor organ transplant ecosystem for bone marrow transplants. So all of this is built on a set of reforms that were made to our organ transplantation ecosystem in the 1980s. Congress passed the National Organ Transplant Act, and essentially what NOTA does is it establishes this network of nonprofit organizations that manage organ and tissue donation, and it creates some basic rules and ecosystems that we build on. All right, so we've developed a process for recovering bone marrow from vertebral bodies and cryopreserving that. So we bank the bone marrow, and it can be used at any later time. And there's a number of advantages to this, and there are things I've hinted at already. The organ donors don't need their bone marrow anymore, so we can recover much more of it than you would ethically take from a living person. Our cryopreservation techniques allow us to keep the cells cryopreserved for decades, thaw them later, and use them. We have very deceased donor bone marrow. The composition of the cells is actually a little different than what you get from a living donor aspirate. If you aspirate bone marrow from a living donor, I don't know if anyone has ever seen a bone marrow aspiration before. What you actually get is a bag of blood with a little bit of bone marrow in it. The peripheral blood has high T cell counts. These tend to drive GVHD. Almost all bone marrow transplants from living donors today are done using mobilized peripheral blood, not because it has better outcomes for patients than traditional bone marrow. It actually tends to have higher rates of GVHD. It's because it's considered to be easier on the donor. Using a deceased donor where you're no longer concerned about the pain of the donor, the inconvenience to the donor, allows you to do a true bone marrow transplant. And then, of course, the cells are available on demand. And so rather than the 3 to 5 month time window you're looking at, if you have to track down a volunteer, it's available in just a few days. So here's some in vitro data comparing bone marrow that was processed at our facility from organ donors to living donor bone marrow aspirate. Focusing at first on the left side of the screen, there are three major things that we look at. First, there's the percentage that are true hematopoietic stem cells. Second, there's the viability of those cells. And then third, there's functionality. So we do CFU assays and confirm that the HSCs that we identify in the bone marrow can differentiate into red blood cells, white blood cells, and platelets. And in broad strokes, what we find is that our product is not distinguishable from living donor bone marrow by these quality metrics. One way that it is definitely very different is the T cell count. We have about 70% fewer T cells in bone marrow that's processed from organ donor vertebral bodies as to what you would get if you used aspirate from the iliac crest of a living donor. And actually, if you compare it to peripheral blood, the ratio is even more stark. Okay, so here's some in vivo data. On the far left, you see what we've done here is we've taken our bone marrow, so that's the deceased donor bone marrow you see in blue and green, and then living donor aspirate is what you see here in yellow and orange. And we've infused this bone marrow into NSG mice, and we're monitoring the chimerism of the animals over an 18-week time period. And overall, what we saw is that there's no statistically significant difference in the percentage of human cells that we found in the peripheral blood of the mice when they had deceased donor bone marrow versus living donor bone marrow. And then here on the right, this is a simple limited dilution study. So we're basically increasing the dose that we gave the animals from 25,000 cells here all the way up to about 400,000 cells here. And what we see is the relationship you would expect, which is that as you do higher dosing, you get higher levels of engraftment. So here we show a secondary transplants. And so in this study, we infused our cells into NSG mice. We then allowed those cells to engraft and reconstitute the animal's immune system. We then aspirated more cells from that mouse and infused them into a second animal. And then we measure the amount of chimerism that we see in the second animal. This is a robust test of the ability of these cells to reconstitute an immune system. And as you can see here, we look at the chimerism in the actual bone marrow of the animals as well as in the peripheral blood. And we do so from a couple of donors. And then we do a sham donor for both. And again, for secondary transplants, these are sort of robust chimerism levels. And this is comparable to what's seen in living donor secondary transplants. Okay, so what do we do with this clinically? So Ossium is partnered with the National Marrow Donor Program's Be the Match registry. And the idea is to eliminate is to dramatically reduce the number of people who go without a bone marrow transplant today. There are many things about the organ donor population that are different from what you get from living donors. The organ donor population, there's 180 million people, adults in the US who are signed up to be organ donors. It's actually a significant majority of the US adult population signs up for organ donation. And the biggest determinant of whether you're an organ donor or not is just the conditions in which you happen to die. If you were in an automobile accident when you were otherwise young and healthy, the chances are quite good that you'll be an organ donor. And so it's a significant supplement to the current registry, which is based on whether or not people have the ability to volunteer to go and be a donor. But one of the biggest things that's going to affect access to bone marrow transplants really is just time. I mentioned earlier that if people don't get transplants, that 45% that doesn't, it's usually because they simply couldn't find a donor fast enough. Our process, basically, if you compare it to the traditional process where you have to find a donor, then do confirmatory HLA tapping on them, handle all the logistics associated with scheduling, the scheduling the mobilization, and then doing the stem cell collection, and then finally distributing. We're basically doing all those steps in advance. Even the confirmatory HLA typing, although we have it here, we actually do sort of next generation sequencing, high resolution HLA typing on all the donors. And so we can simply distribute the cells, and they can be available within about 72 hours. Okay, actually, so this is the conventional application of the product. This is using our bone marrow to fill gaps that exist in the existing bone marrow transplant ecosystem. But that really is the beginning. It's not the ultimate end. There's an enormous number of applications of a bank of bone marrow that is available on demand, that can be, where cells can be thawed and selected or cultured for further manufacturing. And so I'm going to talk about just one of those applications now, and that is medical countermeasures. So believe it or not, this deck was actually put together before sort of recent political events and threats. One of the applications of bone marrow banking that we've been working on for some years now is providing the U.S. government with a rapid response capability. So in the event that there was a radiological or nuclear event anywhere in the United States, you could have anywhere from 10,000, if it was a single city attack, to 50 or 100,000 people who are far enough from ground zero that they're not immediately incinerated in the blast, but close enough that they're exposed to significant amounts of radiation. Anyone who's exposed to more than about 2 gray of radiation is at risk for developing hematopoietic acute radiation syndrome. HARS will often result in death within about 4 to 6 weeks of the event of the exposure. And here you see the chart. Here you see the chart of the frequency of these different cell populations over time, flattening out or bottoming out at around 30 days, when a majority of people who were exposed to sufficient radiations will have been dead by then. And so this is how that breaks down at scale. The way that the US government thinks about these attacks is to really divide them into about 3 categories. There are potential terrorist attacks, which would be a device of about 0.1 kiloton. There are rogue state attacks where you're looking at a 1 to 10 kiloton attack. And then there's a large-scale attack, which would be from another superpower, and that involves an attack of up to 100 kilotons. And then these are their estimates of the number of bone marrow transplants that would need to be done in order to address the medical need. So I mentioned earlier that today, using for people who have hematologic malignancies, there's about 18,000 people who go looking for a transplant in a full year. And there's actually only about 10,000 allogeneic transplants that are done and another 10,000 autologous transplants. In this scenario, we might need to do 50,000 transplants in just a few weeks. It would completely overwhelm the current ecosystem. The current ecosystem has no capability to meet this. And again, the big issue is time. You need to do these transplants in less than a month. Today, it takes 3 times that long to do a transplant when there's not a national crisis. So the Biomedical Advanced Research and Development Authority is the division of HHS that works with companies in developing capabilities like this, and this is one of the lead applications of our bone marrow banking program. Okay, so this is the team on the left. Here are some of our lead investors on the right. And I mentioned a moment ago that treating hematologic malignancies and sort of addressing mass casualties are just a couple of the applications. There are a handful of other studies that we're working on. Most of them, one of them that's important is tolerized organ transplants. So all of our donors are, by definition, organ donors, all of them. And so most immune tolerance induction protocols rely on having access to bone marrow from the organ donor. The idea is that you give those same cells to the recipient of the organ to induce hematopoietic mixed chimerism in the recipient and ultimately get long-term allograft tolerance. So that is one major application of our bank, since 80% of organ donors are deceased. And then there's a handful of other applications as well. Okay, I think I'm going to pause there. Let's see. Okay. All right. Any questions? Okay, all right, move on. Great, thanks.